Well, thank you very much, Hein, and good afternoon, everybody. Kia ora. It is great to be here. I've just come straight from the beehive. It's great to get out of that place, actually, away from an endless cycle of meetings and talk to some real people about what's going on in the health system. I've actually just come from the defence portfolio where I used to get to go to places like Afghanistan and the Pentagon, and I'm now on my DHB tour, but they tell me potentially for a politician that could be much more dangerous, but it's been going pretty well so far. But look, I've set myself a goal of getting around all the district health boards by Christmas. I've been to 15 so far. I'm going to be in New Plymouth tomorrow, and we're on target to achieve that. And I think it is really important to get out of the beehive and actually find out what's happening at the front line. And your feedback as leaders in the health system is incredibly important to me as I shape up my approach to the portfolio. Many of you will know my background. I trained as a doctor at Auckland Medical School. There's one or two of my old classmates in the room here, and one of the pleasures actually of coming into the portfolio has been reconnecting with some of those old classmates again and going around some of the hospitals. Literally, people have been springing out of doorways, as happened at North Shore Hospital when an orthopaedic surgeon there, Peter Much, who I went to med school with, literally suddenly appeared. I don't think it was planned, but he was right there. But look, I just want to thank you for the work that you are doing across the health system. It's very important that we have a health system that's led by clinicians, and I know that you've heard a lot about that. I want to make sure that it's something that really is happening. After med school, I went and did my house surgeon years, first at Hawke's Bay and then back up to Auckland where I did a diploma of obstetrics, and I was assembling all the componentry to go into general practice. I then went off to the UK and I did a GP trainee there, a year there, worked in several hospitals and then had a general practice in London for 3 years. And at that stage I started getting interested in some of the wider strategic issues around health. I went off to business school, did an MBA, and then came back to New Zealand and worked mainly as a consultant for PricewaterhouseCoopers, but I still did 1 day of clinical medicine each week, quite a bit of it in South Auckland actually, down in Otara. And I found that was a really fantastic combination because while I was looking at the health system from a strategic point of view, I was also in touch with patients on a weekly basis. And I think it's very important having that connection so you really know what it is like for the patients out there and what it is like for doctors working in our health system. I came into Parliament in 2005. We had a term in opposition, and then when we came into government, I went into the cabinet, and I've held a range of portfolios in both the social and economic areas since then. So in the first term I was Associate Minister of Health with responsibility for mental health. I've had immigration, most recently state services, associate finance, previously associate tourism, and now, of course, health and sport. So really looking forward to the challenges ahead, and I think it's going to be a pretty busy time. The PM has been very keen to link the sport and health portfolios, and I'm going to talk a bit more about that a bit later. But what I have noticed when I've been going around the district health boards is that fundamentally it feels like a different system to the days when I was working in it. The sites are the same, but you go to a place like Counties Manukau and physically it's totally transformed. And I think in many ways that reflects a lot of thought that's gone into providing better patient services over many years, and we're now seeing that in the infrastructure that's being produced in places like the new ED department in Rotorua, the new neonatal unit down in Otago, and the elective surgery centre in Waitemata DHB. So there's been a lot of change. I've also been struck by how committed those people who are working in the public health system actually are. There's been a lot of change over many years, but I think we've actually moved beyond the politics of health now, where people who are working here in this country are saying, well, look, this is the structure and the system we've got. We want to make it work as best as we possibly can to deliver the best possible service for New Zealand patients. And one thing I ask doctors when I go around the DHBs is, look, fundamentally, does the health system feel better, the same, or worse than 10 years ago? And the universal feedback I've had that although there are real challenges working in the health system, they feel it's going in the right direction and that overall things are better. Now, I know there may be a range of views in this room, but I have found that really encouraging. And one thing I'm very keen to do is take that long-term view of where we're going and, very importantly, what we need to do to deliver great services to the public. One thing I can tell you, though, is I believe I understand the culture of health in terms of I've worked with many people over the years who come from your background. I'm from a similar background in terms of professional interest, although obviously I've diverged off at some stage. But I have an understanding of what motivates doctors and why people choose to work in the New Zealand Public Health Service. And the motivations are complex, but in the end, it's you want to practice your skills at the very top of your game, and you want to see the dial really moved for patients in New Zealand and some long-term achievement of some really complex health problems. So what I can say is the door is always going to be open to talk to the ASMS and to have your views reflected in conversations in the Beehive. And I'm looking forward over the next 3 years to meeting many, many more of you. I feel it's time to check the settings of the Ministerial Review Group, which laid out its plans in 2009. So I've asked the officials to report back to me as to how we're going in terms of some of those changes in structure to the public health system that we made at that time. I've also said to them, and this reflects the feedback I've had from a lot of people in DHBs, that, look, it's time we had a single overriding strategy for health. So if you go to the ministry website, you'll find there's actually something like 164 different documents in the strategy area. But the last time we really had a look at something comprehensive was back in the year 2000. And I don't want it to be a massive opus or something that just gathers dust on the bookshelves. I want there to be one single document which people can go to really get a sense of what the government's direction on health is. Because the feedback I've had is that, of course, DHBs want to be able to exercise their autonomy. And of course, we agree on the overall strategic goals, which is better population health in New Zealand and better outcomes for patients. But the sense I've had is that people want a clearer communication of what the government's direction is for DHBs to get there. So I've got the officials working on that as we speak. I believe overall the New Zealand health system is in pretty good shape, but there are definitely challenges, and there will be into the future. It's never going to feel like there's enough dollars in the system. On our side, the government side, it's a very complex challenge to get the books into balance. But we've come through a pretty difficult period after the GFC, and we've emerged from that world economic downturn with the books in great shape. We've got one of the highest growth rates in the world in terms of our economy, one of the lowest rates of unemployment, and at the same time we've been able to protect our social services and, very importantly, the financial entitlements for the most disadvantaged in our society on the way right through that. In terms of investment in our public health services, that's risen from a budget of $11.8 billion in 2008-2009 to $15.6 billion last year. And I know that those increases aren't the 10% of a decade ago, but we're still putting in around 3% per annum, and that's been actually what the country has been able to afford. The wider context, though, is in my 6 years as a minister, there was only one time when I got any money out of a budget, and that was when we had to do some major re-gearing of the defence portfolio. But health has had significant increases every year, and I think that is something that really puts the overall situation in context. The other thing that I can say is I will be going into bat really hard for health in the budget rounds, because there's no question that as demand increases, we do have to have the health system adequately funded to keep up with that pace and demand. So one thing I've been saying as I've gone around the DHBs is I'm very keen to develop a sense across the system of Team Health New Zealand. And so that means that at all levels, governance, management and senior clinicians and right down through the clinical system, as well as across the Beehive, in the end, we're all striving for the same thing. And we won't always agree on everything all the time. And behind closed doors, there will be tough discussions and, different points of view. But I am keen to develop a strong partnership between government, the ministry, and the health sector. And what I've been saying to chairs of your DHBs is that they have to make sure that senior clinicians have their views reflected at the board table. So it's not good enough for boards not to be talking to clinicians, and actually the clinicians' views are the ones that I really want to hear about. It's interesting to hear from management, and the chairs are there to really implement government policy, but in the end, those DHBs where the clinicians are engaged actually seem to be doing a heck of a lot better than those where the doctors are unhappy. When I'm talking about doctors in this context, because you are doctors, but of course it's a bit of a mouthful saying doctors, nurses, allied health professionals, but I do mean the whole health team, and I think doctors are obviously a really key part of that. So whenever a chair or a CE wants to discuss a new idea in health, I'm saying to them, well, what do the doctors actually think of this? And I think actually if we're going to deliver better integration across primary, secondary and tertiary care, we have to actually have the new ideas coming through from the clinical people. So I'm saying to chairs, look, I don't want to see letterheads mashed together. I'm not really interested in merging executive teams. I'm interested in strategic change where there's a well-thought rationale and where the doctors are saying, look, it makes sense for clinical services to be amalgamated across DHBs. Now, it won't always make sense, but I think it's got to be driven from the ground up, and it's very much a case also of taking the public with us. And basically the reason why we are going to need to continue to configure services is although the rate of growth of expenditure will continue, the rate of growth of demand will outstrip that. So we've got to get more services out into primary care. We've got to work smarter across DHBs. We're working differently 10 years ago. We will be working very differently in 10 years from now. But I'm really keen for the ideas to come from this group, and management and boards have to listen very seriously to you, because how just seemingly small changes actually do make a big difference to how the public receive their health services. So anyway, I was talking about this 20 DHB tour. So 2 days after I got my ministerial warrant, I set off down to Southern DHB to talk about some of those very well-aired issues. And we've continued on from there. The other thing that was on my desk in the first week was the issue of Health Benefits Limited. And so it became apparent that this was something that needed some attention. I've been out, talked to clinical people as well as management and chairs, and the feedback that I had was that district health boards wanted the implementation of those 4 business cases handed back to them. So we have made a very decisive move over the last week, whereby we're saying to the DHBs, okay, you've said you want to have ownership of this issue, we are handing it to you, but actually we do need to make those back office savings across DHBs. And they're big numbers, you're talking $620 million over the next 4 years just for the system to stand still, let alone respond to increasing demand. So we are now expecting the management and governance teams to really deliver on that. But I think that's an example of a problem being presented, seeing that a new path ahead is needed, and we are very much prepared to take action, and the Cabinet was unanimous in that decision. Because in the end, we want to make the savings in the back office if we are going to fund the sort of frontline services that we need. So you can expect that HBL, assuming all the due diligence goes according to script, will be wound down by June 2015. But we've got to keep the momentum up in the interim around making the type of savings that are required to keep the system sustainable. In the medium term, we've also got to maintain a strong focus on improving quality, performance and the financial sustainability of our public health system. And I believe that the health targets are very key in this. They're not just about the numbers, but they're about better and quicker access to important health services. And you'll be familiar with those targets. Shorter stays in ED, That measures the performance of the whole hospital, not just the ED. It really is a barometer for what's happening across the system. In terms of electives, we've lifted elective surgery from 118,000 operations in 2008 to 162,000 in 2013-14. We've also done very well across the DHBs in terms of the cancer targets, so radio or chemotherapy within 4 weeks of being ready. We've now set a new target across the whole cancer pathway. In primary care, we've placed an emphasis on heart and diabetes checks, and we've had remarkable progress in that, helping smokers to quit across both secondary and primary care. We've really lifted performance in that area. And of course, in immunisation, having 92% of 8-month-olds fully immunised, I think, is a huge achievement. So I'm sure there will be debate here around the targets, but in the end, the feedback I've had is that they have given real focus to what the government is expecting from district health boards and from clinicians, and they have lifted performance. As an example, I want to recognise the great work done by specialists and their teams who have brought those elective surgery waiting times down. Nearly all patients are now treated within 4 months. That's been achieved by a huge increase in the number of patients being treated each year, while keeping the same average operation complexity overall. For those of you who aren't familiar with this improvement, it's only a few years ago that there were about 7,000 patients waiting over 6 months, so a great deal of progress there. We're on track to have no one waiting over 4 months by the end of this year. There have been no reductions in access, in fact quite the opposite, with 44,000 more people getting surgery than those 6 years ago. We made some commitments during the election and we intend to honour those. So we're looking at ways we can use targeted funding to deliver better health outcomes for all New Zealanders. So from July 2015, we're going to have free GP visits and prescriptions for under 13s, and that's going to cost $30 million a year. And that money is going to go towards giving 400,000 young New Zealand kids a healthier start to life. As I said, we've also set that new faster cancer treatment target. So 90% of patients are to receive their first treatment within 62 days of being urgently referred with a high suspicion of cancer by June 2017. And that is the international gold standard for care. But we also want more New Zealanders to live pain-free lives away from hospital. To achieve that, we're putting in an extra $50 million over 3 years to reduce pain and increase prevention by delivering 2,500 extra hip, knee and other orthopaedic operations in addition to the usual increases in elective surgery. We're going to provide more than 1,500 extra general surgeries, operations such as cholecystectomies, vein operations, and we're putting $6 million in there to create a multidisciplinary early intervention team focused on pain reduction. That's in terms of joint initiatives. We're also putting in another $20 million into hospice care each year. So, you know, that's something that we've done in response to what's been very clear community demand. Another big theme around the DHBs is the drive for integration. DHBs are trying to develop stronger links with primary care providers. And I've been pleased to hear about things like GPs having direct access to specialist nurse and/or doctor advice, safety programs being delivered on medicines management, and nurses leading clinics on diabetes management. That focus on integrated healthcare needs to continue and it needs to grow and deliver the results we have to achieve across the system. But we've got to be taking the communities and public with us to ensure that we are delivering the best possible healthcare across the population. I'm very aware that there are still at-risk populations who don't have equitable access to health care. We need to do all we can to ensure coordinated care for patients and to encourage stronger links between services, whether in hospital or in the community. Enabling patients to move smoothly between different healthcare providers depending on their treatment needs reduces fragmentation of care and provides a better patient experience. And that fits with the other long-term priority setting, delivering care closer to home. It involves the whole concept of self-care, greater support for people to manage their health in their own homes. Part of care closer to home includes harnessing the full potential of our health workforce, growing the use of pharmacists to help people manage their long-term conditions, and growing the use of nurse specialists. So we've basically got to use all the resources we have out there in primary care, and I think there's going to be plenty of work for everyone. Essentially, we do have to take pressure off our hospitals. So all that is going to help free up specialists to focus on what you do best, which is the delivery of specialist healthcare. One thing I've also been saying to board chairs is that we have to find a way with our fragmented system to transfer best practice from one DHB to another. And I think in terms of governance, management and also clinical practices, we've got a lot of things that are working well across the country, but we've also got other DHBs which across those three dimensions, the practices are not so great. And I've said to chairs, look, you really have to make an effort to actually drive some uniformity in the system. On the clinical side, it's about talking to the doctors, as I've already said, but on the governance side, it's about making sure that great DHB governance practices, like I believe we have in Waitemata DHB, that they can show some other DHBs which may be struggling, some of the things that they've done in terms of mentoring board members, mentoring chairs, and actually very importantly, making sure that we've got good managers across the system, because none of you want to be working with rotten executive teams. We've got some excellent ones, but we've also got some that are needing strengthening up. The third final big area really, so we've got these ongoing challenges in health around the fiscal management, the day-to-day political stuff, all the bullets that fly around politics. We've got the medium-term stuff of getting more care out into secondary care. But the big area where I would love to make some progress, and I'm going to be discussing with my colleagues the issues around that, is around non-communicable diseases. So if you look at the burden of morbidity, obesity is a big driver of that. Reading some documentation today, we're the third most obese adult population in the Western world. Might not feel like it sometimes, or maybe it does feel like it sometimes, but I'm sure from your clinical practice you'll know what I'm talking about. So I'm very concerned about that. I think it's something we need to tackle, not only for the health of our kids and for New Zealanders, but obviously it's a thing that's going to really be important in driving the long-term financial sustainability of the system. So that's why the PM's given me the sports portfolio as well, because we want to leverage physical activity into the health area to a far greater extent. Obviously, there's multiple dimensions to obesity. There's, the physical activity side. Diet is obviously a big factor. Education around diet and physical activity. And I've also been speaking to Peter Gluckman around the work he's doing chairing the WHO committee on obesity, and he's very interested in some of the perinatal factors. So it's multifactorial. We're going to look at the evidence. What we come up with, it may not please everybody. I'm sure it won't go far enough for some of you. We're not going to be doing a sugar tax, for instance. Some of you may want one. But, I want to be very clear and direct with you about what you can expect, and my aim is to under-promise and over-deliver. But what I can say is you should never have any doubt about what I'm thinking on a given issue. So that pretty much covers obesity. In terms of other work we've got going on, the Prime Minister after the election laid out very clearly that he wants to do something about children in material hardship. So across government we're working very intensively on interventions in that dimension. It's not easy, but we're looking for programs and interventions that actually have a range of outcomes in a range of dimensions. So for instance, in my area, sport and health, I've been looking at physical education programs like Project Energise, which is running in Waikato, and it's also running in Northland. I visited a school up in Northland called Mania View Primary School, Decile 1 School, where they brought in Project Energise. What they're finding is the kids are more actively involved in school, less truancy, fewer social problems, and also the evidence around that particular project shows a decrease in waist circumference over time. So I'm going to be talking to my colleagues on Monday about the issue of obesity. discussing with them, possible government interventions, but I just want to assure you that it is on the map, as is the issue of raising living standards for the poorest children in New Zealand society. So anyway, I'm very glad to be in this portfolio. It brings together my professional interests, both from a medical and political point of view. There's a lot of challenges in it. It's a very busy portfolio. When I was Minister of Defence, I had one press secretary, one advisor, and 2 people from the Ministry of Defence. I've now got in health 2 press secretaries, 2 advisors, and 4 people from the Ministry of Health in my office, and they're flat out the whole time. Because it's one of those portfolios where things come through the in-tray on a daily basis. You've got the media harassing you, but also you want to achieve some higher level aspirational things. And I think health could be a great legacy for the government, which I'm a part of. I think we've done a great job in difficult circumstances, probably not pleasing everybody, but in getting the system to where it is now. And there's now an opportunity, I think, to achieve some higher aspirational goals for New Zealanders in the health domain. So anyway, thank you very much for inviting me along today. I'm looking forward to coming back on an annual basis, maybe for another 6 or 9 years in a row, who knows, but we'll see how all that goes. And very happy to take your questions. So kia ora, thank you very much.
We've got a system of roaming mics.
Oh,
so
yep, sure.
Just
That all sounds good.
Hi.
Yes, hello.
Right, looks like I'm the warm-up act for the questions.
Yep, that's all right.
Jeanette McFarlane, I'm the clinical head of anatomic pathology at Auckland Hospital.
Yes.
And I'd like to ask you about the proposed reorganisation of laboratory services for Capital and Coast,
Yep.
the Wairarapa and the Hutt Valley.
Mm-hmm.
In view of the serious and ongoing issues that have been happening in Auckland that arose as a result of the community laboratory transition process, is your government really prepared to risk the Wellington region's laboratory services by going down that privatisation route?
So the first thing is that's an issue which I'm following very closely. I was talking to the chair of Capital and Coast last night, and I've said to her, look, we've had this letter from the ASMS. I'm well aware of clinicians' views on this particular issue. We don't want to do anything that is in the end going to result in a poorer service delivered for patients. And as I said in my speech, or the implication of my remarks is, I'm not interested in getting into firefights which distract from the central challenge which we've all got of providing better clinical services. So if it's not worth the candle, it may not go ahead. But let's just see, there's a process to go through. But as I said, we will be taking doctors' views into strong consideration around that. But the other thing is, I'd say, not everything in the system is going to be perfect. We don't all get absolutely everything we want out of it, and the issue is overall, is the system going in the right direction? So no decision has been made on that particular issue.
To the clinicians in Wellington, and that's been the experience in Auckland.
I know, yep, and I've read that letter from the clinicians and from the ASMS very closely. Yes.
Okay, Ian Page from Northland. Thank you, Minister. Something you didn't touch on, but I think is important, particularly for the Medical Student Association with us. What's been your direction to board chairs about the role of the DHBs and the hospital services with ensuring training continues? There's a risk when we do more work that it gets given to the seniors to do because we can get through it quicker and training suffers. Have you given them any direction?
Well, look, when I go to these DHBs, we talk about a range of things, but I mean, I've had discussions with Health Workforce New Zealand around training, and the expectation is we've still, with this increased throughput in our medical schools, we've got to have not only placements for PGY1 and PGY2, but training for medical students along the way. So, that does have to be accommodated. And we've got to make sure that that's done in a way that you guys can get on with your clinical work, but also the students get their clinical experience on the way through. Yep.
Ruth?
Yes.
We very recently had a major outbreak of Yersinia,
Yes.
As you will be aware, there was a very good case control study done by ESR. That was suppressed, and SMOs were gagged in terms of talking about it. Not by the CEOs, but by public health, we believe. So 2 questions to you.
Sure.
Is it appropriate that SMOs are gagged? And secondly, is it appropriate that food hygiene is under the Ministry of Primary?
Yep. Well, I mean, are you guys gagged? You know,
This person was definitely gagged, without
Yeah.
a doubt. So, in fact, he's been very professional about it. Ian knows about it. In fact, it was the media that came to me about it.
Yeah.
And we have talked about it at a high level in
Yep.
the DHB.
Yep.
It was not at our CEO level.
right. Well, I'm not going to get into an individual case in that, to be honest. I don't have the facts about, you know, this person you're talking about. But, you know, I mean, I think it's important in general terms that, you know, the public get to hear the views of the medical profession. I mean, probably though, you know, you do want to have a channelled approach for that. That doesn't mean we just want good news out there. We want, you know, debate. But you know, in the end, we all work with instructions. So I can't just go out in the public and say what I like, because I've got, you know, my boss I report to too. So, you know, we do have...
This meant that people
Yep.
who could have... people weren't actually aware of the risk factors, therefore they were going
Yeah.
on getting infected, therefore there were more appendectomies being done
Yeah.
because it was... So this was actually... What we felt locally was
Yeah.
that we needed to warn our local population.
Yeah, it's difficult for me to comment on that individual case, is the honest answer. Whether... what's that, sorry?
You can feedback at a later stage.
Okay, well, I haven't got the facts on that one. But look, you're also asking about whether that should be under food safety or public health. You know, there's a bit of debate there, but I mean, I think food safety does do a pretty good job on this stuff, and then the health interface is when you're actually talking about treating people. So, you know, I'm comfortable with where it sits.
But it's under the Ministry of Primary...
Yeah, but there's a food safety section in there. Yep.
Yeah, I think let's move on to the next question.
Good afternoon, thank you for coming. Eric Monasterio, forensic psychiatrist from Christchurch. I would love to ask you a question,
Yep.
and this is in relation to the Trans-Pacific Partnership Agreement.
Yep.
I understand I can't ask you a question because this agreement is held in confidence. I will be giving
a question. Yeah.
I will be giving a presentation in relation to what I believe will be the likely health effects of the TPPA tomorrow.
Mm-hmm.
And in that context, it would be great if you could be present for that presentation and the discussion that will follow. I believe that this is a fairly wide forum of concern by the medical profession in relation to this agreement.
Yep.
But if you are unavailable, perhaps somebody from the ministry can be present and can
Look,
at least hear some of
unfortunately, I
those
can't
concerns.
because I've got these commitments in Taranaki. But look, just in terms of the TPP, so, you know, there has been a lot of comment about the text not being available for public scrutiny. The fact is that's the same with all trade negotiations. It's just how negotiations work. What I can tell you is we're not going to trade Farmac away. So, you know, can give you, you know, that assurance. And Tim Grosser, the Trade Minister, has said that.
Hi.
Fine.
Hello, Dean Conger, Counties Manukau. Are you aware that the general emphasis on cutting down the first specialist appointment time has resulted in longer wait times for follow-ups of chronic conditions?
And you're talking about in which particular specialties?
Ophthalmology, glaucoma, or diabetic retinopathy.
Yeah, look, I know there has been some, you know, commentary out there around, you know, some of these health targets having effects elsewhere in the system. I think, though, overall, you know, you can say that more people are getting their procedures, and then it's up to DHB management to work with you guys to make sure that you're providing appropriate clinical services to the populations that you serve. Now, I mean, there will be different situations in different DHBs. You know, it's a matter of getting the balance right. But, I mean, we wouldn't want people's long-term care suffering, obviously, because of, you know, our waiting list initiatives. But the advice I've had from the ministry is actually that overall it's going pretty well.
There's only a financial penalty for the FSA. There's no financial penalty to the DHBs if follow-up wait times go long and people are harmed. So it's half the story or an unbalanced situation, I think.
Well, if you want to send me some of that data from your department, I'm happy to have a look at it.
Thanks.
Yep. Okay.
David.
I'm David Gallop from
Hi.
the Hospital. Welcome, Minister.
Thank you very much.
Great to hear your plans for the future. Question about HBL, brave
Yep.
move and a good move, we think, to do what you did. The business cases that they've worked up, are you expecting the DHBs to stick with those, or do you think have they got some latitude to change those?
Okay, so in terms of the business cases, I think everyone agrees with the general principles. So it's food, linen, it's basically procurement and the national infrastructure backbone. But I've said to DHBs, look, it's not an opportunity to relitigate, whether those are the right business cases. Most of the savings will actually come from procurement and having the big 6 DHBs involved in there. I think there's a bit more flexibility around things like food and linen, but we've really got to make those procurement savings. And where the flexibility around FPSC, which is the procurement part, will be around the Oracle ERP system and the timing with which DHBs join that over time. So, this has got to be something which the DHBs take ownership of rather than it being done to them. So there is some flexibility, but in the end, we've got to make those savings across the system. And I mean, in simple terms, I don't think the patients, they obviously don't mind where the sheets come from as long as they're clean, or where the food comes from as long as it's fine. But, they won't be happy if they're not getting their clinical services. So in the end, yep, we can have a certain degree of flexibility, but we can't resolve from the business cases overall.
I'm going to call that to an end. Minister's got a tight schedule.
I can take some more questions if you
You
like.
sure?
I've just got
a signal there.
Oh, okay.
One more.
He's worried what I'm going to say next. Yeah.
Otherwise, you get replied.
Okay.
All right. One more question. I think there's a mic over here that's ready to go.
Hi, Sylvia Boyce. I'm from Middlemore Hospital. I'm an emergency physician,
Yep.
and I'm also very interested in actually seeing a target that addresses the unmet need. I know we've had an increased number in elective procedures, but we are also seeing increased numbers of people who are being turned down. They're not even making the waiting list for a first specialist appointment. They're turning up in our EDs. They can't get out of bed because their arthritis is so bad. Can you start measuring those referrals that don't even make it to the prioritisation and actually addressing what that community unmet need is?
Yep. So the first thing is we are measuring it. We've just started doing that. We haven't got any results yet, but no government has ever measured unmet needs. So, we've made that commitment to do that. We're also developing a clinical prioritisation tool so that, rather than just in simple terms focusing on one operation, we're able to decide, which patient gets whatever operation, taking into account a range of variables. In terms of the sort of things you're talking about, patients with really severe arthritis, this is what this pain initiative is about. So $50 million going into the system on top of what's already there. And that's going to fund multidisciplinary pain teams to try and intervene in patients' pain at a much earlier stage so that they don't, actually have to be so extreme in terms of their symptoms before they get their operation. It's about keeping them pain-free for longer. So, we're aware of concerns and we're, measuring need and looking at what we can do in the community. Yep. Okay.
Thank you very much.
Yep.